We are very happy that our paper, The Pocket Creation Method Facilitates Colonic Endoscopic Submucosal Dissection, was accepted. My name is Alan Lafour.
Hello, my name is Yoshikazu Hayashi.
Hello, my name is Hironori Yamamoto. We are faculty at Jitsu Medical University, Japan.
So to begin, I have a question for Yamamoto Sensei. What's the most important point when we perform colonic ESD?
Thank you for asking me. Achieving a cure is the most important consideration when we resect neoplastic lesions. In order to achieve this goal, both complete local resection of the tumor and complete control of metastases are required. Inability to control metastases is a clear limitation of endoscopic treatment. Therefore, accurate assessment of the risk of lymph node metastasis is required when we consider expanding the indications for endoscopic resection of colon tumors.
So how do we assess the risk of metastatic disease? Hayashi Sensei.
Thank you for asking me. Intramucosal colonic tumors do not have any risk of lymph node metastasis. However, invasive cancers need consideration for lymph node resection according to the risk of containing metastatic disease. The risk of lymph node metastasis from submucosal invasive cancers can reliably be estimated by examining risk factors such as the depth of submucosal invasion, presence or absence of lymphovascular invasion, and histopathological classification based on evaluation of high-quality pathological specimen obtained by endoscopic resection. A high-quality specimen for accurate pathological evaluation requires an en bloc resection, negative margins, and a thick layer of submucosa with minimal thermal damage, because almost all factors predicting the risk of lymph node metastasis are included in evaluation of the submucosal layer. A superficial tumor with a suspicion of submucosal invasion must be resected as a high-quality pathological specimen.
Well, may I take it that it's unnecessary to stick to an endoscopic en bloc resection when we resect an intramucosal colonic tumor? Yamamoto Sensei.
Well, that is still controversial, but another advantage of ESD is very low local recurrence rate. In my opinion, it is also ideal that even intramucosal tumors are resected in an en bloc fashion with negative margins to avoid local recurrence. Piecemeal resection is known to have high rate of local recurrence, and once local recurrence occurs, then the next treatment becomes very difficult. So still, en bloc resection is ideal, and ESD is a very good method to achieve local en bloc resection.
I see. Well, as you know, it's technically difficult to resect a large superficial tumor with conventional endoscopic mucosal resection, or EMR techniques, which use a snare to perform a true en bloc resection with negative margins, when the tumor is bigger than 2 centimeters in diameter or has severe submucosal fibrosis, etc., even if the tumor is intramucosal. A considerable number of large superficial tumors, or those in difficult locations, are resected surgically, even if it could be cured by complete local resection.
I agree. However, endoscopic submucosal dissection (ESD), which is a more sophisticated technique than EMR, is now available to overcome the limitation of snare resection and achieve an en bloc resection regardless of tumor size, shape, location, or degree of submucosal fibrosis. ESD is gradually spreading to many countries in recent years with increased interest in less invasive curative treatment for superficial gastrointestinal tumors. However, it is supposed that ESD is much more technically demanding than EMR. and requires intensive training and extensive experience to obtain adequate skill to perform ESD.
Well, tell me, does the pocket creation method give good results for ESD?
Yes, absolutely. We established the pocket creation method, PCM, as a strategic method for ESD to provide a high-quality pathological specimen and secure a safe and reliable ESD procedure. If you perform ESD according to the PCM manner, you realize that almost all ESD can be completed without significant difficulties. As our paper shows, even a relatively inexperienced endoscopist can perform ESD with PCM better than with conventional methods. We strongly recommend the PCM to trainee endoscopists wanting to obtain ESD skills from now on as their standard ESD strategy.
Hayashi Sensei, could you please explain the advantages of the PCM?
Yes, thank you for asking me. Although the PCM was originally developed to overcome difficult ESD for large cell tumors, the PCM has many advantages for general use in ESD. The PCM facilitates ESD by maintaining mucosal elevation, providing good traction and visualization in the submucosal layer, enabling a tangential approach in difficult circumstances and stabilizing the tip of the endoscope in the pocket, regardless of cardiopulmonary movement.
I understand. I've heard of a similar ESD method referred to as the tunneling method. Yamamoto Sensei, who originally introduced the tunneling method for colonic ESD? Could you explain the difference, please?
Okay. I wrote a paper explaining the usefulness of the tunneling method in colonic ESD for the first time in 2010.
Is that true? Did you develop the tunneling method for colonic ESD also?
Yes, I did. I started colorectal ESD in 1998 using a needle knife and sodium hyaluronate solution and ST hood. From the beginning, I recognized that dissection of the submucosa and the vertical margin is important. And Dr. Tsuneo Oyama presented the theory of tunneling method for esophageal lesions earlier in Japanese journal. However, because I realized its potential value in colonic ESD, I introduced this method in the colon and rectum and reported in English. I can say that PCM evolved from the tunneling method.
If possible, could you tell us how the PCM evolved from the tunneling method?
Yes, I can. As I told you, from the beginning of ESD, I was using ST hood and sodium hyaluronate solution to visualize the submucosal tissue during the dissection to secure a good vertical margin. And tunneling method was started as an extension of my approach, prioritizing submucosal dissection of a mucosal incision. But I changed the technique and the name because I realized that completion of the tunnel penetrating through the other entry is cumbersome and not necessary. And it is more important to widen the pocket to complete the submucosal dissection under the tumor than to complete the tunnel. With the name tunneling, completion of a narrow submucosal tunnel from one entry to the other is emphasized. However, with the name pocket creation, widening of the submucosal pocket to complete the submucosal dissection can be easily imagined. Therefore, I changed the name and the technique to pocket creation method.
I really understand the usefulness of the pocket creation method. If anyone wants to know this in greater detail, please read our article. Thank you very much for your attention. Goodbye.
Thank you. Bye-bye.
Bye-bye.